So if you look up here for a second, pronation is an anterior motion, right? Look at my radius. My radius is coming forward, yes? So that means it's a posterior glide. Posterior for pronation. You can memorize it as PPP, proximal, radial ulnar joint, pronation, posterior glide, but it's better just to understand it. I don't like memorizing stuff because there's so much to memorize. All right, and therefore, if pronation is a posterior glide, then supination is going to be an anterior glide. I don't do a lot of the distal radial ulnar joint. You know, if you guys want me to show you that glide, I'm happy to, but most of the time, if patients have limited pronation and supination, it's at the proximal radial ulnar joint, and then remember the ulnar triquetral joint. So the ulna with the TFCC, that joint gets limited, and will affect supination in particular. Okay, so that's the elbow. All right. You know, it's probably gonna be easier if I just do this. Yeah, we should do it like this. Okay. So remember, the shoulder's 4 joints. So if you are doing passive range of motion to the shoulder, I've literally seen therapists blocking the scapula and trying to get the arm all the way overhead. You only have 120 degrees of glenohumeral motion, so don't block the scapula if you're doing passive range of motion. It has to move 60 degrees to get full elevation. So that's always been a head scratcher for me. And then AC joints, a planar joint with a disc. I took a lot of AC joint mobilizations out because I don't use them, because typically it's irritable. The AC joint, even with grade 2 oscillations, you really just kind of make it pissy. So, you know, if you want to learn that stuff, I can teach it to you, but I just took it out of my practice. Typically what's going on with the AC joint, it's hypermobile. You need to lock it down. And unfortunately, there's not a lot that connects there. So I usually just do a taping technique, which we'll do this weekend. And also, that AC joint brace, it looks like a woman's racer back type of bra with the X. It kind of loops around the clavicle, it loops over the clavicle near the coracoid, and it just pulls you into retraction and holds you there. That's usually, that's mandatory if I have a patient with AC joint pain. SC joint, I don't really go after all that much. But when it is limited, you gotta pull the techniques out, because there's, you know, you can mobilize the scapulothoracic articulation or the glenohumeral joint all you want. I typically see SC joints in mixed martial arts and wrestlers, because they get thrown on their shoulder a lot, they land, and they damage that clavicle. We actually had a case on it last week with someone who had that happen, and it almost punctured their lung and was misdiagnosed for months, which is bizarre. I don't know how you misdiagnose that, but all right. So the SC joint is actually convex. It's a little fist into the clavicle. So you're going to mobilize it in the opposite direction. So if their patients usually have problems with elevation, you're going to do an inferior glide. So if you want me to show you that, it's simple enough to do. When they're kind of like just mixed martial arts, they're kind of hypermobile and crunchy. I just pretty much oscillate them from the front, and the direction doesn't matter when you oscillate. The direction matters when you're doing grade 4s. So I'll say that again. The direction doesn't matter when you're oscillating, right? It's just for pain and viscosity. So do the easy one. But if you have a tightness, you have to push it in a direction. So typically, if the SC joint's limiting something, it will limit elevation, which means inferior glide. All right. All right, so the scapulothoracic joint, it's not a true, it's not a true joint. It's actually technically called an articulation because there's no joint capsule. You do have a burst on the other side of it, so this does get crunchy. So everything I just said is kind of like anatomy nerd stuff. So you can call it a joint. It does get crunchy. I mobilize it all the time. If you have a patient with shoulder pain, you should be mobilizing the scapula. Okay? Just like if you have a patient with knee pain, especially anterior knee pain, you should be mobilizing the patella. Like, it's just stuff you do. So I see therapists sleep on this. After a shoulder surgery, I'm doing scapulothoracic mobilizations for at least 5 minutes, at least. All directions. Submax isometrics, normalized tissue. We'll practice all that this weekend. Okay. And then all the press goes to the glenohumeral joint. Typically, if you have shoulder dysfunction, I want you to write this down. Some of your primary, this is what you see, like, in most of your patients with shoulder pain. You see a tight posterior capsule with a loose anterior capsule. Okay, there's a couple slides on here called obligate translation. So basically the posterior capsule gets tight, it pushes the humeral head forward, and then, people are also stretching abduction and external rotation, and they shouldn't, and then they get this anterior shoulder instability, and subsequently, it doesn't hurt, but then they start getting shoulder impingement, and then they come in because they got supraspinatus or infraspinatus pain or biceps tendon pain, because they're getting, subacromial impingement. So, tightness of the posterior capsule, anterior shoulder, anterior glenohumeral instability. Other things, they get subscap guarding, they get weakness in low trap and serratus, and weakness in the posterior rotator cuff. So, I'm looking, when I see any shoulder patient, those are like the many things I just listed, 6, 7 things, those are the things I'm looking for. And typically they'll check 4 or 5 of those boxes out of 7. They don't have to check all of them, but that's typically what patients with shoulder dysfunction have. So, and then your long-handed biceps is considered your 5th rotator cuff muscle because it attaches under the acromion here and onto the labrum, and it helps. So if I ask you right now what the rotator cuff does, I bet the vast majority of you would say, well, subscap does internal rotation, and infraspinatus, teres minor do external with supraspinatus, and supraspinatus also does abduction, and that's fine on a basic like year 1, year 2 OT or PT school, okay? But when things work together functionally, what the rotator cuff's real job is 2 things. One is centration of the humeral head, so it keeps you from dislocating. Okay. The ligaments only do 20% of that job at the humerus, so that's why I don't distract the humerus a lot. Okay. You look over here for a second. Stop. If you're doing that stuff, just stop. I don't know what this is, but just stop doing it. Okay. Now, why do we do it with the leg? Well, now it's an anatomical question, and you see it clinically. If I do that to you, you immediately pull back. I can feel your muscles. If I do that to your hip, you relax. It's the exact opposite effect. Because your body knows that if his muscles don't contract, I'm ripping his arm out of the socket without a lot of force at all. Because 80% of the stability here is his rotator cuff with biceps. 20% is capsule ligament. In the hip, it's 80 to 90% are capsule ligament. Muscles don't have to do much at the hip. I can pull on his leg, the muscles actually relax. That's actually a good treatment to relax piriformis, is pull on the hip. Treat out 4-5 oscillation, pull on the hip, that turns piriformis off. Okay. Why did I mention piriformis? Every joint has a muscle that likes to go to guarding. At the shoulder, it's subscap. At the hip, it's piriformis. So, anyway, you can do distraction, but I'm going to show you a different way to do it. And the muscles will stay relaxed because it doesn't sound like you're pulling the arm out of the socket. 80% stability. Okay, I think I hit everything there. Oh, yeah, long-handed biceps. So, long-handed biceps job with the rotator cuff is job 2. So 1 centration, 2 is inferior glide. When you go over your head, your humerus has to drop. And that's why most patients with shoulder pain, that classical lateral arm pain with the elevation, that painful arc, is subacromial space impingement. So that the biceps helps to press the humeral head. And so if you're having anterior shoulder pain with elevation, it's probably more longhand biceps. If you're having lateral arm pain with elevation, it's probably more posterior rotator cuff. And out of the two, it's got to be infra and supra. Can be teres, but. So if you have to train those muscles together. So I do a lot of inferior glide early on, which looks like this. And this is in your exercise manual. So I have the patient put this in a door frame at home, up top like this, and then I have them just do inferior glide like this. This is one of my early exercises. They do inferior glide like this. They do external and internal rotation, all 3 sets of 25. If they have subsap guarding, they do 3 sets of 40 internal first. And then they do inferior glide and external rotation at 3 sets of 25. And then my secret weapon, if you're not doing this with your shoulder patients, these 3 things early on, and this, okay? Okay. I stopped trying to get patients' arms over their head in supine. I stopped altogether. The farthest I get them is like 120, just to get into subscap and do some soft tissue on subscap. I don't push them at all. I don't push them at all. Okay, I strongly recommend you do this. Coming out of school, shoulder, like I told you, was my least favorite because I was terrible at it. I've actually learned how to treat the shoulder really, really well. Okay, and I didn't figure it out. I had good mentors that showed me. A little trial and error on my part. Okay. And why I keep bringing that up is I don't want you to think this is like some magical experience that somebody can just through osmosis, like say, oh yeah, no, I know how to treat that well. Or how I hear people go to courses and hear like these gurus say, oh yeah, I made all this stuff up. No, you didn't. You just went to other people and learned it, and then now you put your own name on it. So I want you guys to understand. And then another thing is just anybody can learn this stuff. You know, anybody can do this stuff. Okay? But I want you to watch this for a second, okay? Now remember, what's on enclosed chain? Everything. Everything's on enclosed chain. And what does the shoulder need? It needs stability. So when the shoulder is actually weight bearing, the subscap guarding reduces because it's stable. Remember, the subscap guarding is there because it's trying to accentuate an unstable shoulder. So when you're doing this, it's guarding, which changes all the mechanics of the scapula, and then you start getting impingement. That's why you're getting impingement and weakness of the lower trap, serratus, okay? So you ask them to do this, and they do this kind of thing, all right? Or you do an open chain on the table, and they're resisting you. Now watch this, okay? And obviously I don't have shoulder pain, but try it with your patient next time, and I promise you, you're gonna do 95% less work. You're just gonna, after you do the hands-on on the table, so glenohumeral grade 2, scapulothoracic grade 2, soft tissue to the subscap with some X isometrics, you're gonna get them up. They're still gonna, have a little thing. It'll be better, but you're gonna do this to them, okay? So I'll do it for you guys, then I'll change. You're just gonna have them do this. It's comfortable, just roll it out and just lean into it and just don't have any shoulder pain, just go as far as you can. You're gonna see they get about 20-30% more motion, okay? Now this may not look like a lot, okay? But I wanna show you this, okay? Even if they're doing it down here, they're not really getting a whole lot of motion, but they just lean into it a little bit, drop their hips a little bit. That's 160 degrees. When I took my hand off the ball, I didn't raise it, okay? All I did was I just stood up, okay? Watch my shoulder. I'm not changing my shoulder position. That's 150, 160 degrees. So stop trying to supine range your patients to end range and just have them do it on the ball. Now, how are they gonna do this at home? Well, it depends. A lot of times it's not for stretching. So it's not gonna be like this 50% once or twice a day. It's more about tissue healing and vascularity. So they can do this, 5-6 times a day if they want. Now they might not have time to do all that, but this is something that they wanna do after they do their band exercises that are gonna normalize their tone a little bit. this would be kind of the last exercise they do. Or you can just do it like this, like you can post-op, and not go towards that above 90, and this is a great exercise to do to detonify. Or do it side to side like this. Okay. The other way I do this is in a chair. So I'll have them sit, and I'll have them with their elbows on the table, and then just go back and forth like this. And it's the same principle. 150 degrees. And it won't be a struggle for them. It'll be really easy for them to do. And the science behind it is, it's weight bearing, and when your shoulder muscles, when your shoulder is compressed in the joint, it actually normalizes tone. And if your subscap has high tone, it's going to normalize, and then you're going to get more elevation, more abduction, extra rotation. Okay. In the afternoon, we're going to do a nice soft tissue to subscap, nice soft tissue progression to subscap, and that's what you would do before you did this stuff. Okay, unless they're normal, of course, then you're just doing it. A lot of this is just anatomy review, so I'm not. Because of the cases last week, didn't I go through thoracic outlet? I remember doing that. I went through the 4 entrapment sites and auto test, I did that whole progression. Okay. So there's a whole, I did my fellowship capstone on adhesive capsulitis. So the chances you're going to see a true adhesive capsulitis are very low, especially out here. It affects more, well, it's Orlando. I'm talking like I'm in Miami. And, Miami's obviously heavy Latin. There's not a lot of Northern Europeans, people of Northern European descent in Miami anymore, so that this is where it highly affects it. It also affects women more than men because true adhesive capsulitis is an endocrine problem. True adhesive capsulitis is an endocrine problem that presents as a musculoskeletal problem. They have high or low thyroid. They're perimenopausal or premenopausal. That's why it happens in women more than men. It's linked to hyperthyroidism. I said that. It's linked to hyperlipidemia. So, how do you know what you're treating? The biggest thing I can tell you is that it is the onset. So a lot of people say I had no problems, and then I did something one day, I went to the gym, I cleaned out my garage, all that, and then my shoulder started hurting and I was losing motion. That's not adhesive capsulitis. Adhesive capsulitis is, they have a, and I hate to use these metaphors because they're just, to me they're just dumb, but it's like, the freezing stage. So, if you want to use that, for 3 to 5 months, they start to feel stiffness in their shoulder and slowly turns into pain. If they are in that group and they're in their 40s and they're a female and they have some of these endocrine issues, including diabetes, your ears should perk up. And why I talk about this a lot, because if you're getting physicians that are sending you diagnoses with adhesive capsulitis a lot, it's not adhesive capsulitis. They're writing something, and they don't even know what they're doing. And when I say that is they don't understand the implications on rehab. Because for them it might not matter, but for us it matters. Okay? Because if you're treating someone with shoulder impingement, it should look completely different than a true adhesive capsulitis. Adhesive capsulitis is an inflamed capsule your normal stretchy type 1 collagen is slowly turned to type 3 collagen for reasons we don't know. That's linked to the endocrine system. And then that type 3 collagen is not stretchy at all, and your shoulder's inflamed. And basically, you just have to stretch the patient through pain, which is something we don't normally do. And it's going to resolve in about 18 months from the time they start to feel stiffness. And that means probably about 4 to 5 months before they're sitting in your office, because nobody comes in and says, hey, my shoulder's a little stiff. You know, I'm going to take an hour off of work and pay $40 and, you know, my shoulder's a little stiff. No, they wait until they can't raise their arm anymore or wash their hair or, you know, reach behind their back and clean themselves in the morning when they're going to the bathroom. Like that's when they usually come in. So what typically happens is somebody does something over the weekend, and within a week they're in their office because they just either have a partial rotator cuff tear, or they have inflamed supra, infra, long head of biceps, etc. And now they can't move their arm really well at all. And that's acute shoulder impingement. So your job when you see adhesive capsulitis, is this acute shoulder impingement or is this adhesive capsulitis? If it's truly adhesive capsulitis, you need to refer them back to, you can treat it, but they also need to go to their GP and make sure their diabetic meds are on point, their cholesterol meds are on point. A lot of times it's female, so I tell them to go to an OBGYN and have a hormone panel done and see if they're eligible for hormone replacement therapy. Hormone replacement therapy, guys, doesn't cause cancer with most women. So that's a misnomer out there. So hormone replacement therapy is actually very beneficial to women. So it's something that's not talked about a lot. So the low energy, brain fog, musculoskeletal presentations, these are all things that can be treated with hormone replacement therapy safely with most women. So if you're seeing the shoulder issue, the neck issue, the plantar fascia, and the person sitting in front of you is female and over 40, send them back to the OB and have them get a consult for HRT. All right. And if it's a man sitting in front of you, same thing for testosterone. Have them get a testosterone panel. All right. Treatment for adhesive capsulitis, I said you got to stretch it. So typically you're going to do grade 4 mobilizations and alterations and try to keep their range and keep the exercise light and just explain to the patient they're going to go through this process of 18 months. If it was my shoulder, I'd go in for a capsular release. That's just how I would do it because I'm not going to sit there and not have my shoulder use. But I bring this up to patients. Like if this is confirmed, you're in month 4, you're in for another year. If you can wait that out, great. If you want to get mobility back in your shoulder, I would pursue an arthroscopic surgery where they can release your shoulder capsule. That has long-term problems too, right? Because when we know that people that have arthroscopic surgeries, they get faster joint degeneration. So they should know that side of it too. But for me, I'm not going to not have my shoulder for a year. Can't work, can't play with my kids. That's not going to be a thing. So that would just be a personal opinion. You know, and that's it. If it's shoulder impingement, like I haven't seen a adhesive capsulitis case in 18 years. You know, so I see a lot of it on a script that says someone has adhesive capsulitis, and you know, when you can clear up their symptoms in 2 weeks and get their arm over their head, it's not adhesive capsulitis. Yes.
What happens if we're seeing a lot of post-op adhesive capsulitis?
Well, that's just ridiculous. And that's what I mean. When I said they don't know what they're doing, they don't like they don't
the same doctor.
They haven't been trained that adhesive capsulitis isn't shoulder impingement. They just think adhesive capsulitis is just a garbage pill diagnosis like shoulder pain. I'd rather have them just say shoulder impingement. But basically that's what they're saying. They're telling you they have shoulder impingement. You know, I would bet they don't have adhesive capsulitis.
Well, then it confuses the crap out of the patients too.
Yeah.
But you said that, I'm like,
Yeah.
and then they go to Google.
Yeah, then if they go to Google, right, because that's when Dr. Google gets involved, or now ChatGPT, then you got real problems, because then they're like, so I'm not going to be better in 18 months, and then this whole, you know, certain people are fine, but it's, you know, people that catastrophize, then it's like, okay, now I'm dealing with all these mental things, you know, emotional problems, and they're scared, and I feel bad for them when they get to that point, you know. It's kind of like fibromyalgia. I don't see that as much now. But I don't know, like 10 years ago, every freaking patient was coming in with fibromyalgia. It's like they're over 50. They have arthritis in like 8 joints with muscle guarding. Like they have tender points in 12 different spots. I get it. because they have arthritis in their neck and their shoulders and their knees and their hips, and they're eating shit food and they're 100 pounds overweight. Like, it's not fibromyalgia. I mean, because I get, you know, when you get on the fibromyalgia, like, apps, like, you know, the Reddits and shit like that, it's just like your life's over. You know, people get divorced, you know, they get back, you know, they're, you know, if you get, I don't know what fibromyalgia is, but if you have fibromyalgia, I feel bad. Like, it's almost like a modern day cancer diagnosis. Because you're gonna be depressed, you're gonna lose all your friends, you're probably gonna lose your relationships, and you're gonna be in your house, you know, maybe if you have a supportive partner, they'll stick around. It's truly, like, devastating to have a real fibromyalgia case. Most of it's just, you need to eat cleaner, and you need to handle your depression and anxiety, and lose some weight, and see a physical therapist and get your trigger points treated. That's usually what it is. So, yeah. Anyway, sorry for that. We're in a safe space, right? This is what I want to tell people. I'm much better in front of a patient, by the way. I'm a little more patient with this. I just open up with you guys, because it's like, I swear to God, if I won the Powerball, I would have like 5 minutes at the Super Bowl. I would just take out like 1 minute commercials like every quarter and just, hey, this is your friendly PT. Just reminding you, don't stretch that hypermobility. And by the way, spine pain is just like leg pain, so don't put heat on it if you have an acute injury. Things like that. The more you know. COT. So anyway, all right. I think this is good. So just this is a whole thing. It explains the etiology of it. I basically just summed it up for you, but it also explains the treatment, and it goes through that. It actually shows, it shows you the actual physical microscopic changes that happen. So like it's all there for you. If you want to use that for your physicians, like you use these slides. You use the slides. Use the slides. Just cut them up in an order. You know, you don't want to give them like 20 slides, but you can go in with like 3, 4, 5 slides. And be like, look, this is impingement, this is adhesive cap, this is the differences, you know, you gotta treat it differently. But I mean, that might be like, you know, the next echelon. But if you have like a good relationship with the surgeon, like, you know.
He doesn't like therapy.
He does not, yeah.
Okay.
He literally waits 2 seconds until no return.
So that's, yeah. And that tracks, because that tracks. I mean, usually the people that don't like therapy are gonna do things like that where they don't understand it.
I should say he doesn't like us because he gives them exercises to do at home. So it's really us.
Oh my God, that's the worst. Oh, you got shoulder pain. Oh, here's these 6 exercises to do. It's like,
Just do this.
are you shitting me?
He literally said, just.
We went to school for all this time and all I needed was a paper handout for exercises? Like, doesn't that insult you?
Yes.
Like that's just, like to me it's like it's unbelievable. It's unbelievable that I get this reaction because when I joined this group of 20 surgeons, they would do shit like that. And I had a relationship with them where I went up to them, I'm like, well, how do you know they need those exercises? And they look at me like, what do you mean? I'm like, well, what did you do to test to make sure that they actually had weakness in that muscle? I didn't do anything. Okay, well, why are you giving them that exercise? You don't even know why. You're like, this isn't just like copy paste. Here's 6 exercises, and they're like, oh, I didn't know you guys like did that specific of an exam. I'm like, yeah, it's a 40-minute physical exam. You know, and I didn't say the next part, which is obvious. I didn't do the 5-minute thing you do. I didn't talk to them for 3 minutes, send them an X-ray, and bring them back and give them some pills. Like I actually did something. I put my hands on them. I actually tested muscles, length, strength, joint mobility. Last time I checked, only DOs do that, and they don't even do it most of the time. So, anyway. It's just like when you, like, I'll leave it here. Like, when you have all this research that shows that if people just saw a PT first with musculoskeletal pain and save hundreds of billions of dollars, just the United States, like, come on. Like, send them to rehab first. Anyway. So, all right. So this one's cool. So there's still some, like, even today, there's still some, like, what actually is it? So you do see changes in blood flow in the arm. So I think there's a big sympathetic nervous system issue with this that goes with your hormones. You know, we talk about these systems as silos, but they all interface with each other. So you see things like microcirculation might be an issue. By the way, adhesive capsulitis is related to Dupuytren's. It's actually the same process. And people that get adhesive capsulitis have something like a 40 or 50% chance of getting Dupuytren's, which is that fascial tightening in your hand. Okay.
Yes.
And the last time I checked, what's the treatment for Dupuytren's? Oh, that's right, they surgically release it. Oh, okay. All right, so why would we do that at the shoulder? I have no idea. So, but this is from 2005, how long we've known this, but there's you know, that's why diabetes affects your blood flow with your staining your glucose in your blood. So basically, it's thought that this might be why diabetes is affecting it, because it's affecting blood.
Inflammation.
But that's a whole piece. You're not gonna get a lot on that. Like, don't think you have to read all these pathology slides and all the slides. I made this residency level, so you guys, if you wanna learn more, you have it. The anatomy slides are there, but you are responsible for the arthrokinematics, and then things like thoracic outlet and like the obvious stuff. When I say the obvious stuff, like joint, muscle, tendon, that kind of thing. You do have to know adhesive capsulitis is an endocrine issue. You could get a question on that within musculoskeletal presentation, because you should understand that. Yeah.
In your review, do you do examples of test questions or anything just so that?
Yeah.
Oh, okay.
Yeah. The PTs will take a midterm. I'll give you guys a practice test, and then you guys will take your final.
Okay.
But you'll get a practice test first.
Okay.
Yeah. That, no stakes. And then the PTs, you guys get like a midterm, not like, you get a midterm exam, 50 questions, and then your final exam's on, I think, 100 questions. All right. Great. So that's the review of anatomy and et cetera. So if you guys can let's wait for the PTAs to